Welcome to the Deep Dive. Today, we're taking a plunge into drug toxicity and poisoning. We're going to explore how even medicines, things meant to help, can sometimes have harmful effects, and also what happens with substances that are just plain poisonous. It's pretty fascinating stuff.
Yeah, it really is. And for this deep dive, we're drawing on a really solid chapter covering the whole topic. It starts with the basics, like how dose affects response, and goes right through to prevention and treatment. It's, the big picture. We're here to pull out the key ideas for you.
Exactly. Think of this as your quick guide to the core principles. We'll hit those aha moments and maybe some surprising facts, but keep it manageable. So to kick things off, what is the difference between a drug and a poison here?
Good question. So from a pharmacology view, a drug is basically any substance that causes a physiological response. Now, that response isn't always good, right? It can be adverse. A poison is broader. It's really any substance that can cause harm. So, while a pharmaceutical causing harm is acting like a poison, not all drugs are poisons at normal doses. When we talk about poisoning, we usually mean those bad effects from meds, illicit drugs, or chemicals.
Got it. So it's the harm that matters, not necessarily the intent. Now, a really central idea here is that the amount you take is critical. Dose matters.
Absolutely. That's the dose-response relationship. For one person, you usually see a graded response, more drugs, stronger effect up to a point. Like taking more painkiller gives more relief.
Makes sense.
But for a whole population, we look at the quantal dose response. That's about the percentage of the group showing an effect. It's sort of an all-or-nothing thing. The effect either happens or it doesn't. Helpful or harmful.
And this leads to terms like LD50 and ED50.
Exactly. LD50, that's the median lethal dose, the amount fatal to 50% of a population. And ED50 is the median effective dose, a dose that works for 50% of the population. And these let us calculate the therapeutic index, or TI. That's just LD50 divided by ED50. It's like a quick safety check. Generally, a bigger TI means a wider gap between a helpful dose and a deadly one.
So a drug with a TI of, say, 10 is safer than one with a TI of 2.
That's the general idea, yeah. Something like penicillin has a really high TI, huge buffer.
Assuming no allergy, of course.
Right, assuming no allergy. But then you have drugs like digoxin for heart issues or many cancer chemotherapies. They have low TIs, very narrow window, needs careful dosing.
But the sources say just looking at that 50% mark isn't the full story for safety.
No, definitely not. Because the way the response increases with dose can be different for the good effects versus the bad effects. The slopes of those curves matter.
How so?
Well, imagine 2 drugs, same LD50. But for drug A, just a tiny bit more than the effective dose starts causing serious problems in lots of people.
Yeah.
Really steep toxicity curve. For drug B, you might have much more wiggle room before toxicity kicks in, even with the same LD50. So a high TI based on those middle points, the 50% marks, could be misleading if the danger ramps up fast.
I see. That makes perfect sense. So is there a better way to gauge safety then?
Well, one alternative is the margin of safety. Instead of the 50% mark, it looks at the LD1, the dose lethal in just 1% compared to the ED99, the dose effective in 99%.
So focusing on the edges of the response curves.
Exactly. It's a more cautious comparison, looking at where things start to go wrong for the most sensitive versus what works for almost everyone.
Now, I always kind of pictured these dose response curves as, smooth lines going up, but the sources mention some really weird shapes.
Yeah, they're not always straightforward, non-monotonic curves, they're called. The response doesn't just keep climbing. Take essential nutrients like certain vitamins or metals, you can get a U-shaped curve.
U-shaped? Yeah.
Too little is bad deficiency, too much is bad toxicity. There's a just right zone in the middle, homeostasis.
Like iron. Need some, but too much is dangerous.
Exactly like iron. Then there's the hockey stick curve.
Hockey stick? Okay.
You see this with some toxicants, like formaldehyde, perhaps. At really low levels, your body just deals with it, detoxifies it, no effect. But once you hit a certain point, you overwhelm those defenses, and boom, the harm shoots up sharply, like the blade of the stick.
Right, after the flat handle part. Okay.
Yeah.
And the last odd one was an inverted U.
Yeah, the inverted U. This can happen, for instance, if the body's receptors get overloaded or downregulated at super high concentrations. Think maybe estrogen. Normal high levels do their job, but extremely high levels might actually cause the effect to decrease because the body tries to tone down the signal.
Interesting.
It really shows why you have to test a whole range of doses to see what a substance truly does.
Absolutely fascinating. Okay, so the body's processing ADME. Absorption, distribution, metabolism, elimination is key. What happens when a toxic amount hits the system?
Well, yeah, poisoning can really throw a wrench into the works.
Ah.
Normal pharmacokinetics, how the body handles a drug, usually basically becomes toxicokinetics under toxic conditions. The rules can change.
And those changes matter for treatment, right?
Hugely. Key questions become, if someone seems okay now, how long do we watch them? How long until absorption and effects might peak? And if they're already sick, how long will it take their body to clear the poison? That's about elimination and dynamics.
The aspirin example really drove this home. How absorption changes in an overdose versus a normal dose.
Right. Normally you take aspirin, peak blood level in maybe an hour. Quick. But in an overdose, aspirin can cause the stomach valve, the pylorus, to spasm shut.
Oh, wow.
Yeah, so the aspirin gets trapped in the stomach instead of moving to the small intestine where it's mostly absorbed. Plus, tablets, especially coated ones, can clump into a big mass of Bezor. Less surface area for absorption.
So absorption is slowed way down.
Way down. Instead of peaking in an hour, the highest blood level might not hit for 4 or even up to 35 hours after taking the pills.
That's a massive delay.
Right.
Really shows why you can't assume someone's fine just because they seem okay initially. And the source listed other drugs with potentially delayed symptoms too.
Yeah. Table 4.1 points out several where significant symptoms might take more than, say, 4 to 6 hours to show up after an oral overdose.
Yeah.
Common ones like acetaminophen, aspirin itself, but also things like illicit drugs in body packs.
Okay.
Certain antidepressants, MAOIs, diabetes drugs called sulfonylureas, sustained-release pills, thyroid hormones, valproic acid.
Valproic acid, the seizure med?
Yeah, that one. Also warfarin, the blood thinner, and drugs with anticholinergic effects because they slow the gut down.
And there was a specific point about valproic acid sticking around longer in overdoses.
Yes, exactly. Normally, its half-life is maybe 14 hours, half the drug gone in 14 hours. But in overdose, the body's breakdown pathways get saturated, overwhelmed.
So it clears much slower.
Much slower. The half-life can stretch out to 30, even 45 hours. That means the toxic effects can last a lot longer.
Okay, so we've got dose response, how the body handles things. Now let's get into the different ways therapeutic drugs themselves can cause harm.
Right. Because most drugs do more than one thing, right? We just want the one therapeutic effect. The other effects can be just bothersome side effects, or they can be actually harmful toxic effects.
And the source breaks down these toxic effects. Let's start with the dose-dependent ones related to how much drug is there.
Okay, so these are predictable, generally. More drug, longer exposure equals greater risk or severity. The source splits these into 3 main types: pharmacological, pathological, and genotoxic.
Okay, pharmacological first. What's that?
Pharmacological toxicity is basically too much of the drug's intended effect. Like barbiturates, they slow brain activity. Higher dose goes from sleepy to coma. It's predictable.
Mm-hmm.
Or nifedipine lowers blood pressure. How much it lowers, it depends on the dose. Even phototoxicity, where some drugs make your skin extra sensitive to sun, fits here. It's a direct drug-light interaction at relevant doses.
Okay. And pathological toxicity, what's the damage there?
This is where you get actual tissue or organ damage. The classic example is acetaminophen overdose. Normally, it's broken down safely. But a minor pathway makes this reactive thing, NAPQI. Usually, glutathione in your body neutralizes NAPQI instantly.
But not an overdose.
Right. If you take way too much acetaminophen, you use up all your glutathione. Then the leftover NAPQI damages liver cells, causes liver necrosis.
Wow. Clear example. And the third type, genotoxic.
Genotoxic means damage to DNA, our genetic material. This can cause mutations and down the road, potentially cancer. Things like, ionizing irradiation or many chemotherapy drugs, they have genotoxic potential.
Okay. Now, separate from these dose things, there are allergic reactions. How are they different?
Allergic reactions are your immune system overreacting. It mistakenly sees the drug as a threat, usually needs prior exposure, sensitization.
Right.
The source mentions 4 main types, based on which part of the immune system is involved. Key thing is, it's not about the amount of drug in the same way as the others. Even tiny amounts can trigger it in someone sensitized.
Let's quickly run through those 4 types. Type I is anaphylactic, the fast one.
Yeah, type I, immediate, often severe anaphylaxis. IgE antibodies are the culprit. On re-exposure, they trigger mast cells and basophils to dump histamine and other stuff, causes rapid swelling, vessel dilation, breathing problems, affects gut, skin, airways, blood pressure. Think bee stings, severe food allergies.
Scary stuff. Type 2 is cytolytic. What happens there?
Right, type 2 involves IgG and IgM antibodies. Can lead to destruction of blood cells, like penicillin, causing anemia in some people. Usually stops when the drug is stopped.
Okay. Type 3, the Arthus reaction.
Type 3 involves immune complexes, clumps of antibody and antigen. These complexes get stuck in blood vessel walls, cause inflammation. Serum sickness is a classic example. Rash, joint pain, fever. Takes a bit longer to show up, usually clears up a week or two after the drug is gone.
And finally, type 4 is delayed hypersensitivity. Takes a while.
Exactly. T cells, specific immune cells, are the main players here. They recognize the allergen, release inflammatory signals, but the reaction, like a rash, is delayed. Poison ID contact dermatitis is a common non-drug example.
Okay. Beyond dose and allergy, there are also idiosyncratic reactions. What's unique about those?
Idiosyncratic reactions are just weird, rare, unpredictable responses in specific people. They don't really fit the dose-dependent or allergic patterns. One idea is maybe the drug unexpectedly binds to a protein, creating something unique that only that person's immune system reacts to. A bit of a mystery sometimes.
And of course, our own genetics play a huge part in drug response. Pharmacogenetics.
Absolutely huge. Our genes dictate how we handle drugs. The source gives great examples, like about 10% of males of African ancestry lack enough of an enzyme, G6PD. If they take certain drugs like primaquine, their red blood cells can break down. Hemolytic anemia.
And genes affect metabolism speed too, right? How fast we break drugs down.
Definitely. Variations in genes for metabolizing enzymes, like NADI2, affect how quickly someone handles isoniazid for TB. Or CYP2C9 and VKORC1 variants change sensitivity to warfarin.
The blood thinner.
Right. And then you have CYP3A4 and CYP2D6. These enzymes handle tons of different drugs, so genetic differences there can really change a drug's half-life, effectiveness, and especially the risk of drug interactions.
Which is a perfect segue. Drug interactions are another big source of trouble.
Oh yeah, very common. People are often on multiple meds, plus OTC stuff, supplements, even diet matters. They can interact, leading to treatment failure or, unexpected toxicity.
How do these interactions happen? The source groups them by mechanism.
Right. One way is messing with absorption. One drug changes how much of another gets into the bloodstream from the gut. Like ranitidine-reducing stomach acid can increase absorption of some other drugs.
Interesting.
Or cholestyramine can bind to drugs like propranolol in the gut, reducing their absorption.
What about interactions involving blood proteins?
So, many drugs bind to proteins in the blood. Only the free unbound drug is active. If drug A bumps drug B off its protein binding site, you suddenly have more free active drug B.
Which could cause problems.
Exactly. Increased effect may be toxicity, especially risky in overdose or if someone has low protein levels. Aspirin, warfarin, some seizure meds are known for this.
Metabolism breaking drugs down is another big interaction point.
Huge. One drug can speed up or slow down the enzymes that metabolize another drug. The cytochrome P450 enzymes in the liver are key players. For example, chronic heavy drinking can induce or rev up an enzyme called CYP2E1.
Okay.
That same enzyme helps break down acetaminophen into that toxic NAPQI thing we mentioned. So heavy drinkers might be more prone to liver damage from acetaminophen overdose because they make more of the toxic stuff faster.
Wow. Okay. What about interactions at the receptor level?
Yeah, one drug can block another from binding to its target.
Right.
Like buprenorphine for opioid addiction, it binds really tightly to opioid receptors and can block the high from other opioids.
And finally, drugs can just interact based on their overall effects on the body.
Exactly. Two drugs doing similar things can add up. That's an additive effect. Or sometimes the combined effect is even more than just adding them that's synergistic.
Like aspirin and heparin, both increasing bleeding risk.
Perfect example. Need careful monitoring if used together. Or sometimes drugs have opposing effects, which can actually be used therapeutically, like using two different types of diabetes meds together to lower blood sugar more effectively.
The source also classified interactions by outcome. Additive, synergistic, potentiation, antagonism. Quick rundown.
Sure. Additive is 1 + 1 = 2. Synergistic is 1 + 1 = 3 or more. Potentiation is when drug A makes drug B much more toxic, even if drug A isn't toxic itself in that way. And antagonism is when one drug blocks or reduces the effect of another.
And that can happen in different ways.
Yeah, they might have opposite bodily effects, react chemically. One might affect the other's ADME, or they compete for the same receptor.
It really shows how vital it is for healthcare providers to know everything a patient is taking. Okay, let's shift focus to prevention. How do we stop poisoning?
Prevention is key. The source focuses on two big areas: reducing medication errors in healthcare and preventing poisonings at home.
Let's talk medication errors first. Sounds like errors happen more often than actual harm results.
Generally, yes. Errors can creep in anywhere: prescribing, dispensing, giving the med, taking it. The 5 rights are the bedrock. Right patient, right drug, right dose, right route, right time. Trying to catch errors.
But mistakes still slip through. The Swiss cheese model.
Yeah, it's a useful analogy. Think of layers of safety systems like slices of Swiss cheese, each with holes, potential weaknesses. An error, like a tired doctor, a misread label, an interruption, that's a hole. An adverse event happens when the holes in all the different slices line up, letting the error get all the way through.
So multiple layers of defense are crucial.
Exactly. Strategies include things like unit dose packaging, having pharmacists prep IVs, keeping dangerous meds locked away, special protocols for high-risk drugs, better drug info access, education for staff and patients, and good access to pharmacists.
And technology helps long-term.
Definitely. Computerized physician order entry, CPOE, where systems check doses and allergies automatically. Barcoding meds for verification, electronic tracking, these are big helps.
Okay, shifting to home prevention. Poisonings happen in various situations.
Right. Table 4.2 lists them. Accidental therapeutic toxicity, kids exploring, environmental or job exposures, recreational use, simple mistakes taking meds, self-harm attempts, and even intentional harm by others.
And prevention strategies are either passive or active.
Yeah. Passive ones are best because they work without ongoing effort. Think child-resistant caps, limiting pill counts per bottle, making products less toxic.
Like automatic safety features.
Exactly. Active strategies need constant effort, like always storing chemicals out of reach, harder to sustain perfectly.
It's good news that childhood poisonings have dropped dramatically, though.
Yes, huge success story. Largely due to those passive measures, like safety caps on so many things now, plus much better public awareness and education.
Okay, so despite prevention, poisonings still occur. Let's talk treatment principles. What's first?
First things first. Stabilize the patient. Keep them alive. Remember ABCDE. Airway, breathing, circulation, disability, checking consciousness, exposure, what were they exposed to? Supportive care is paramount.
Breathing, heartbeat, the absolute basics.
Absolutely.
Once they're stable, what are the next goals?
Then you focus on reducing further absorption of the poison, enhancing its elimination from the body, and if possible, using specific antidotes to counteract its effects.
The source mentioned toxidromes, patterns of symptoms. How do they help?
Toxidromes are super useful clues. They're distinct clusters of signs and symptoms linked to specific poison classes. By looking at vital signs, pupils, mental status, skin, etc., doctors can often make an educated guess about the type of poison before lab results are back. Sure, Table 4.7 lists several. Like, the sympathomimetic toxidrome thinks stimulants like cocaine usually involves agitation, fast heart rate, big pupils. Versus the cholinergic one may be from pesticides with lots of drooling, tearing, slow heart rate. Recognizing the pattern guides early treatment.
Are standard urine drug tests useful in an acute poisoning emergency?
They're mainly for detecting drugs of abuse, and results can take time. They might confirm exposure, but don't always tell you what's causing the current severe symptoms.
So limited use right then?
Often, yes. But getting specific blood levels for things like acetaminophen or aspirin can be very helpful if you suspect those. And an ECG is vital for checking heart effects.
Okay, decontamination is often next. Trying to get the poison out, what methods are used?
Right, stopping more from getting in. Skin or eye exposure. Wash, wash, wash with water.
Simple enough.
If swallowed, GI decontamination might be considered. Historically, things like making people vomit with ipecac or stomach pumping, gastric lavage were common.
But not so much anymore.
Not routinely, no. Evidence shows they don't consistently help and can have risks, like aspiration. So their use has really declined.
What about activated charcoal? Still used?
Yes, but more selectively now. It's a fine powder that binds many poisons in the gut, stops them being absorbed.
How does it work?
You drink it or get it via a tube. It has a huge surface area to absorb toxins. Dose is based on weight. But it doesn't work for everything. Not alcohols, corrosives, metals, hydrocarbons. And it can cause vomiting or constipation, so risks need to be weighed.
And whole bowel irrigation, flushing the system out.
Yeah, that involves drinking or getting large volumes of a special electrolyte solution via tube to literally flush the GI tract. Used sometimes for specific things like body packers, hiding drug packets, big iron overdoses, maybe patches still in the gut, or drugs that form bezors or are very slow release.
Got it, but not for everyone.
No, definitely not if there's a bowel blockage or perforation risk.
Okay, what about helping the body eliminate poison that's already absorbed?
Several ways to speed up elimination. One is changing urine pH, making it more alkaline with intravenous sodium bicarbonate. This helps trap weak acids like aspirin or phenobarbital in the urine so they get excreted faster, called ion trapping. Needs careful monitoring, especially potassium.
Any others?
Multiple doses of activated charcoal, MDAC, can sometimes help. It interrupts the drugs circulating between the liver, bile, and gut, and can pull some drugs out of the blood into the gut. Useful for certain drugs like carbamazepine or theophylline.
And filtering the blood. Dialysis.
Exactly. Extracorporeal removal, hemodialysis or hemoperfusion. Used for severe poisoning with specific drugs that are small, water-soluble, not too bound to proteins, and have a small volume of distribution. Things like salicylates, methanol, lithium, valproate sometimes.
Finally, antidotes. Specific counteragents.
Yes. These are crucial and available. They work in different ways. Some block the poison's receptor, like naloxone for opioids.
That's a classic example.
Right. Others have opposite physiological effects, like glucagon for beta blocker overdose. Some directly bind and neutralize the poison antivenoms for snake bites, chelators for heavy metals.
Like magnets for metals?
Kind of, yeah. And others change how the body metabolizes the poison, like fompizole for antifreeze or methanol poisoning, blocking the formation of toxic breakdown products. Table 4.9 lists quite a few. But remember, supportive care managing seizures, blood pressure, breathing is always fundamental.
This has been incredibly comprehensive. Thank you. To wrap up, where can people find reliable info on poisoning?
Good question. There are detailed toxicology textbooks and databases like Poise Index professionals use. The National Library of Medicine's website, especially TOEXnet resources, is great. But for immediate help, the most important resource in the U.S. is the Poison Help Hotline. 1-800-222-1222 connects you to your regional poison control center, staffed 24/7 by experts.
Excellent. Okay, so summarizing our deep dive, we've looked at that complex dose-response relationship, including those weird curves. We explored how the body handles toxins differently under poisoning conditions, toxicokinetics. We covered the many ways drugs can harm: pharmacological, pathological, genotoxic, allergic, idiosyncratic, and how genetics and interactions play a role.
Right.
We also hit on preventing medication errors and home poisonings and the core principles of treatment, from supportive care and decontamination to enhancing elimination and using antidotes.
Yeah, hopefully giving you a clear, concise understanding of a pretty complex area, highlighting the key stuff without getting lost in the weeds.
Exactly. And we'll leave you with this to think about. Considering all these variables, genetics, interactions, the body's defenses, how does this massive individual variability impact the ethics and practicalities of developing new drugs and deciding who should get what dose?
It's a really big question in modern medicine.
Something to ponder. Thanks for joining us on The Deep Dive.